muscle. That's the law of diplopia. Okay. Let's go back now. When do you get 6 nerve palsies? Answer, a weird nerve with a long intracranial course. And in neurosurgery, we find patients with slowly developing raised intracranial pressure get a 6 nerve palsy. And the one that I see is chronic subdural hematoma in elderly people causing a 6 nerve lesion. And it is also said that this sometimes can be a false localizing sign. What does that mean? It means you can get a left rectus weakness 6 nerve palsy, whereas in fact the hematoma is on the right. I've never understood that, but it's a fact, okay? So if you can come later and tell me why that is, I'll be over the moon. I'm always learning things from my students. I mean that, by the way. I am, because, you know, I'm not the brightest thing on 2 notes. Right. But the other thing to say is 3, 4, V1 and 6 lie in this complicated venous structure called the cavernous sinus. And occasionally, with infections in the so-called dangerous area of the face, where the veins go back into this cavernous sinus, a horrible condition, we can get cavernous sinus thrombosis developing from infection. If that happens, then the patients get a 3, a 4, a 6, and they have V1 numbness, because all of those nerves are in the lateral wall of the cavernous sinus. The other thing that can happen in this region, this is a lousy diagram, is that this is a little bit better, is the carotid artery. This is the cavernous sinus. The carotid artery can rupture slightly into the cavernous sinus in a head injury. And that is called carotido-cavernous fistula. And as a consequence, you get a build-up of pressure in the veins, the eye becomes engorged, and the patient develops 3, 4, and 6, because this is now arterialized and pulsating. They have a pulsating feeling in their eye. You put a stethoscope on the globe of the eye, and you'll hear whoosh, 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 carotido-cavernous fistula, where the carotid artery is now joining. And we sort that out now by interventional radiology, very clever, whereas in the old days, I used to put bits of muscle up into the carotid artery and try to block off the fistula. Can you believe it? Little bits of muscle floating up into the carotid artery, trying to get it into the fistula. We used to put little bits of black thread on the muscle in case it went the wrong way and pull it back again. I can't believe we did these things, but we did. And it worked, if you were lucky. Anything to show here? Yes, or just a little bit of anatomy that's really quite strange. The facial nucleus 7, the 6th nerve wraps around it. Okay. That has some significance in that certain lesions in this region will get both 6 and 7 as a brainstem sign. Let's go back to the 5th. Now, this is a very important cranial nerve, also for exams. Remember that the trigeminal, called trigeminal because it has 3 main sensory branches as well as motor, ophthalmic sensory, maxillary and mandibular. So here is ophthalmic, here is maxillary, and here is mandibular. But also remembering that the trigeminal has, of course, motor as well as sensory. The sensory nucleus is very, very long indeed. In fact, the sensory nucleus goes right away down in the cervical spinal cord. From the pontine area here, it goes right away down to about C2. Is there any clinical significance of knowing that? Yes, there is. Because we get a disease called syringomyelia or syringobulbia, where we get a cavity developing in the central canal of the spinal cord that catches the descending fibers of trigeminal, and the patients start to get numbness in the face. In fact, the fascinating thing is that the lamination of the trigeminal nerve inside the sensory bit, inside the cervical cord, the lamination is such that the patients get numbness from the outside of their face and progressively inwards. So this area of the face is spared with the syrinx. And this is called the so-called balaclava distribution of sensory loss. Does anyone know what a balaclava is? Yeah, I do. My granny once knitted me one. I think it's a photograph of little Terry Hope with a balaclava helmet, aged about 4, in 1951, 52, when you weren't even thought of. Okay. Somewhere in our house, I might still have it. So that's the so-called balaclava distribution of sensory loss. For me, this area is very important because we're in the region of the pons, and the cerebellar-pontine angle is not far away. And when I'll show you some pictures of this in a moment. When I deal with acoustic neuromas, I've got to be very careful with this nerve. The other thing about this nerve is it sometimes gets, as it's exiting from the pons, an aberrant blood vessel pressing on it, which we think is the commonest cause of trigeminal neuralgia. And whereas most cases are helped by drugs, carbamazepine being the classic, we guys, neurosurgery, if carbamazepine is failing to help, we will go in and take the little blood vessel off here and put a little sandwich underneath it, a little slip of an alcoholic vinyl sponge. So that's a little bit of fun neurosurgery, decompressing, the vascular decompression of the trigeminal nerve. So when we test the motor aspect, we must test masseter. Do you want to put the lights up for a minute, Hannah? Thanks. We must test the pterygoids, and we must test the temporalis. So one of my colleagues at the front here is just, his ascending reticular formation is just occasionally letting him down. Would you like to come, I'm really choosing it, would you like to come and test my trigeminal motor? Lights up, Max, on it. So I'm going to sit on the couch here. Okay?
Okay. My name is Malcolm. I'm a fourth-year medical student.
Nice to meet you.
I've been asked to test one of the nerves near your face. Is that okay with you?
That's fine. You're not going to hurt me.
No, I'm not going to hurt you. I'm just going to ask you to make some movements with your jaw, and then I'm just going to have a feel.
Okay.
And then I'll let you know what I find.
Okay.
Is that okay? So can you just do what I'm doing? Can you open your jaw wide for me? And can you move it around side to side?
So tell them what you're doing.
So the trigeminal nerve innervates the masseter muscles. That's right.
What about this? Calm. What's that?
Pterygoids?
Yeah. Right. Okay. So at least I'm doing the movements, and now he's going to test the power in a minute. Okay. And what else?
So can you clench your teeth for me, please?
Right.
Yep. So I'm just feeling for the muscle bulk.
Carry on. Carry on.
Yeah. Temporalis. Okay, can you continue clenching your teeth for me?
Okay. Right. Now, what about pterygoids? Testing power of pterygoids.
Okay, and just move your jaw side to side.
No, I don't go like that. You be the victim. Okay. Right. I want you to open your jaw as wide as possible against my hands, right? Now, a person with a pterygoid weakness, the jaw slings across, okay? So that's what I find the most useful way of testing pterygoids. It's nice to see that he asked me to do that, but if you actually have pterygoid weakness, open wide, it will come over to one side, okay? Like so. So you're quite right. Clench your jaws tight, temporalis, masseter, pterygoids, okay. Right, well, whilst we've got you here, have we got something like a little bit of... Right, that'll do. Well, no, it won't. No. I think I might have some cotton wool in my hand bag. No, I haven't. I'll tell you what we'll do is we'll use a pin for my trigeminal sensory. Right, show them how you would test my trigeminal sensory. Just gently, you know.
Pretty sure it's going to be appropriate?
Yeah.
Okay, I'm just going to touch you on different parts of your face. The touch will feel like that.
I like that. The fact he's actually introducing the scared patient with the amount of needle pain. Okay?
Okay, so if you just close your eyes for me, and when you feel touch, just say yes.
Yep. Why are you asking me to close my eyes, by the way?
So that I can see that you can actually feel it. and not that you're seeing.
I don't bother with that, but anyway, okay. I take the point.